Kia ora, I'm Andrew Jones and I'm an Improvement Program Manager at Auckland District Health Board. I have worked in healthcare for around 20 years, previously as a physiotherapist, and for the last number of years in the improvement world. I'm here today to share with you about some work we did here at Auckland Hospital on improving our estimated dates of discharge and their impact on elective surgical planning. So for those of you who may have had contact with the DMAIC structure as part of Lean Six Sigma, I'm going to have a tracker on the screen that you'll see throughout the presentation that you can see which phase that I am talking about. So what is an estimated date of discharge? It's essentially the date that the surgeon, in this case, forecasts that a patient will be able to go home based on what they estimate is to be a reasonable length of stay for that patient and for their condition. From a process perspective, why does that matter? Why does that matter to the organisation and why does it matter to the patient? So it is often a significant concern for patients. So especially well, in any circumstances, whether you come in acutely or for planned surgery, knowing when you're going to go home is part of your journey and being able to plan what next. And for the organisation, why are they important? Because electives are often cancelled. But it's because we don't have a good understanding of actually what our volumes are like. And we have a pretty good picture of what our acute occupancy is going to be day to day. But at around 85% of the time, we're right about what that's going to look like. But unfortunately, it's only 50% of the time for elective surgery. And while that only makes up 20% of our inpatient volume, it does have quite an impact on our ability to plan when we are running really close to the line in terms of available bed capacity. And when our elective demand can swing from like 8 patients in requiring beds to 31, that can have quite a significant impact each day. So when we looked at this piece of work, we identified that, look, going after services or conditions that are managed through an enhanced recovery process was a really good place to start. Those processes had a number of systems already built in and planning components to their work. And we thought that that would be a good way to be able to sort of forecast length of stay. So the two services who use enhanced recovery after surgery are colorectal and orthopedics. And specifically within orthopedics, we looked at total hip joint replacements and total knee joint replacements. As you can see from these charts, the colorectal patients very rarely had an estimated date of discharge entered into their booking on our PAS system, and whereas orthopedics almost universally had that entered. But the thing about that is, even though orthopedics had them entered into the system, they were rarely accurate. So while they were there, they were not that much help. So then I guess the first step we took was to map out the process and understand what were the likely failure points when it came to EDDs. So while there are a number of other steps and other functions and processes that occur through elective surgery, the ones we wanted to look at were specifically related to estimated date of discharges. And we found 3 really clear root causes. The first one being that the surgeons didn't always enter a length of stay onto the booking form, making it hard for the booker to enter it into the system. The bookers didn't have a standard process, so there was real variability even within services. And the estimated date of discharge itself wasn't being pulled through from the booking system onto the ward whiteboards. So there wasn't that information available to the charge nurses when the patient arrived on the ward. So for each of the root causes, we looked at different solutions. And for the one where there was no guidance from the surgical team, We had a range of different possibilities, starting with a table of standardized length of stays based on different factors like age and procedure, through to a personalized length of stay that was completed at the pre-admission appointment prior to hospital admission. The other option, which was sort of the middle ground, was that it was estimated at booking by the booking surgeon. So when we looked at why it wasn't being captured, as you can see, there was not the option for specificity. So the booking form itself had a day case option, an overnight, but then had sort of ranges for completion, which when you're wanting someone to enter a specific length of stay into the booking system, didn't allow for that capability. So the change was made to the booking form and added in that specificity of having the number of nights up to a week, because from that point, it was viewed that it was difficult to forecast, and that update could be made on the ward. The second thing was to standardize the process. So with the data actually coming through on the booking form, it allowed us to provide some training and quick sheet guides for the bookers to be able to use to ensure that they entered an estimated date of discharge against every patient when making the booking. The third issue was, even though, say for orthopedics, almost 100% of their bookings had estimated date of discharges, none of those were coming through onto the ward whiteboard. And there was rework occurring for the charge nurse, who was having to input on the day their best estimate. What we found was that there was a bug in the background, and that was readily resolved, allowing for the EDDs that the bookers entered to be pulled through onto the ward whiteboard, as you can see here. So having made these 3 improvements, we had a look at the data again. And as you can see, for colorectal, there was a huge uplift in terms of estimated date of discharges being entered as part of the booking. However, for orthopedics, we saw a drop. And while that was initially a surprise, we were able to clarify that because of the original processes the bookers had been following, which was just to put in a standard plan length of stay of 5 days, regardless of what the was on the booking form, that they had moved to entering in the forecasted length of stay from the booking form, and they found that actually not every patient had a length of stay on the form, so they were unable to do it for all patients. But what was being entered was more accurate. And so as a result for both of this, we saw an uplift in the accuracy of the first estimated date of discharge. And while they're not hugely successful in terms of forecasting, the change in process meant that we actually had the data available to start to think about what might be next steps and changes we could make in the process to ensure more accuracy of the estimated date of discharge. What was really exciting was seeing the impact of actually having these 2 services who and these 2 patient groups who, while they don't make they make up a significant number of patients who have surgery, they're not by no means the majority of patients who are having elective surgery. But you can see we saw a 10% uplift in patients having an EDD entered, and we also saw an increase in the accuracy of that EDD across the whole system just by working on these 2 cohorts of patients. So having gone through this learning journey, what we found was that there were some key principles that should be in place and some best practices to be established. We worked on these with the surgeons, the bookers, the charge nurses on the ward, and clinic nurses. And really there were just some real key points, which was every patient should have an EDD, and that should be based on the estimated length of stay that the booking surgeon puts on the waitlist form. This should also be the same length of stay that the surgeon discusses with the patient, so that the patient has certainty at least to whatever degree is possible at that point, to know what the plan is when they come into hospital. The forms we changed, allowed for a specific length of stay to be entered, and we identified that there are a number of other forms that had the same requirement to be changed, so that would be done in the future. And also to have the bookers following a consistent process so that they ensured that an EDD was entered whenever an inpatient stay was created. To monitor this and to see whether it's been successful, a suite of measures were identified around discharge planning that included the 2 elective measures. So every week, a charge nurse will receive a report showing how they're going against our key discharge planning metrics. There's also service level reports that are sent to the service clinical director, the business manager, and to the booking manager to be able to identify where there are opportunities to improve. So at the time of doing this work, we focused on 2 services that we knew had opportunity for improvement, and they were one of many. So with the tools that we had in place, we provided that information to the services with, I guess, a handbook for how to improve your EDD accuracy. And we have left that to them to complete at a local level.